Hello, everyone. I hope everyone is doing well and everything like that. Today, we're going to be going over kind of an interesting section, something that we don't kind of mystified me, and I didn't really. It was kind of interesting when I went through it in the class, so hopefully, you'll think the same way. We're going to be going over the drugs that affect the nicotinic system. Just a little bit of housekeeping to let you guys know what's going on. I received some feedback from people saying that they wish I would go slower through the different topics. And so, in order to do that, what I'm going to do is I'm going to divide the sections up a little bit better, so that way things are a little bit slower for you guys to understand them, and that way, if you have questions, you can reach out. Again, this is mostly just so that way you can have an exposure to the material before you learn it for the first time. But hopefully, you'll be learning something new, and we'll have a good time. Um, the uh, other thing to be aware of is that uh, the previous video was all about going over the problem set as well as myasthenia gravis. So you haven't listened to that, I would highly recommend. And without further ado, let's jump right in. Now, to start off, we're going to be talking about the nicotinic receptors. And what's important to know is that, much like our muscarinic receptors, the nicotinic receptors also respond to acetylcholine. And what you'll notice is that these nicotinic receptors show up in multiple different places in the nervous system. We have them in the somatic motor pathway on the skeletal muscle. And we also have the nicotinic receptor at the preganglia in the autonomic pathways, in both the parasympathetic pathway and the sympathetic pathway. Now, even though the nicotinic and the muscarinic receptors uh, are both respond to acetylcholine as their ligand, notice that they are in different places, and so they have different functions. And so as we go forward, we're going to be looking at these two different locations where we're going to have the nicotinic receptor at the neuromuscular junction, and we're going to have the nicotinic receptor that's in the presynaptic ganglion in the autonomic system, nervous system. And we're going to be referring to the nicotinic receptors on the muscle as the muscular or muscle nicotinic receptors. And then we're going to be referring to those in the autonomic pathway as the neuronal nicotinic receptors. And it's important that we make these distinctions because we're going to find that there are some drugs that affect both, there are some drugs that affect only one kind. And so we're going to make sure that we remember that. Other locations that we can find it is in the adrenal medulla. You can also find it in the central nervous system, a couple of different places. But for the most part, we're going to be focusing on these two different locations, the neuromuscular junction and the preganglia. Now, it's important to understand about the nicotinic receptor is that it's a pore, it's a ligand, it's a, it's, let me back up. It essentially acts like a pore, allowing for certain substances, mainly ions, to flow through it. And that pore is made up of uh, five subunits. And there are different arrangements of these subunits in different ways. You know, we can have this neuronal, this muscular, or this neuronal configuration. But the big thing that I want you to have a takeaway from is that you can see that it's it's acting as a pore, allowing for certain ions to flow through it. And so when the nicotinic receptor is stimulated, what we're going to find is that it opens, allowing for the flow of some sort of ion through the channel. And this open closed state of the alpha subunits is what's going to allow for the control that we're going to be seeing on these nerve impulses. And remember that nominally one of the big things that flows through these nicotinic receptors is the sodium ion. And it's going to be flowing down its concentration gradient from outside the cell into the cell, which is going to depolarize it. That's going to allow for an action potential to be generated, and it's going to lead to a nerve transmission somewhere else. And that's either going to culminate into a muscle movement, or it's going to activate uh, some sort of postsynaptic ganglion. And so what you have to know at this point is that the subunits, the nicotinic receptor acts like a ligand gated ion channel, and that allows for sodium to flow through it. Now, what we're going to be finding as we go through the nicotinic receptors is that we're going to be looking at a kind of interesting application of the muscle nicotinic receptor antagonists and the agonists. And then we're also going to be talking about nicotine, which is where the nicotinic receptor gets its name from. We often name receptors after the exogenous ligand that we find binds to it. So the nicotinic receptors responded to nicotine, so that's why it was named. The muscarinic receptors were stimulated by a drug or a chemical called muscarin, so that's where those got those names. Now, it wouldn't be fair to start off with the nicotinic receptors without talking about nicotine, which is a full agonist, meaning that it's going to have the maximal effect on the nicotinic receptor that we expect. And nicotine can activate all nicotinic receptors, whether that's in the muscle, in the CNS, in the adrenal medulla, doesn't matter where it will go. And because of that, we can see the different effects relating to those different kinds of nicotinic receptors being stimulated. We see an increase in blood pressure and heart rate. We see an increase in sweating, an increase in GI motility, which you could say could come from the stimulation along this parasympathetic pathway that's going to increase this muscarinic activity. Same way, we'll learn about how the stimulation of the sympathetic pathway will increase the activation, which will uh, increase her blood pressure and our heart rate as well. You can also see that when someone takes a drag of a cigarette and they inhale that nicotine, that they're going to, you might know that they get the decrease in drowsiness, or people do it to relieve stress because it decreases anxiety. And then also, too, it has a relaxing effect on the skeletal muscle. And we'll kind of circle back to that idea of why it might relax the skeletal muscle in a bit. But for what we have to know right now is that these are the reasons why people use nicotine products, is that it has fairly good feelings coming out of it. And that's why it's used. Now, there is a known mechanism of physical dependence on uh, regarding nicotine. And that's because when someone uses nicotine, their body slowly becomes dependent on the stimulation of the nicotinic receptor in order to have normal function. So, as long as the person every so often takes a drag on a cigarette or inhales some sort of nicotine, maybe they get it by chewing tobacco or in some way or another, as long as they get that hit of nicotine, then the body is completely fine. It acts completely normal. However, when they lose that stimulation, whether the person is trying to quit, whether the person is, they ran out of cigarettes and they don't have another to resupply, it's going to see some of the withdrawal symptoms indicative of the nicotinic receptor or the nicotine addiction, which is the withdrawal symptoms of anxiety, insomnia, irritability, not being patient, stuff like that. And so what this comes up with is a way, we need to think of a way to decrease that. If people want to come off of nicotine and to stop smoking cigarettes, then we need a way for their the receptors to be stimulated so that someone doesn't go through withdrawal, but it's in a safer form than a cigarette. And so this brings us to an idea of a partial agonist. And the drug that we're going to be looking at right now is varenicline, or you might see it in your pharmacy as Chantix. Now, varenicline is a partial agonist at the nicotinic receptor. So both nicotine and varenicline both bind to the nicotinic receptor and cause that stimulation. And of course, we know that it's going to open, which is going to allow sodium to flow in, and then we're going to have those effects that we were talking about. What's important to know about partial agonism is that it can act like antagonism at the receptor, and it has to do with competition. So let's say at 100% is that nicotine responding and stimulating the nicotinic receptor. Well, a partial agonist is going to have some fraction of stimulation for that receptor. And so what that means is that when the varenicline binds to the receptor instead of the nicotine, when it binds instead of the nicotine, you're going to get a much smaller response than what the nicotine would have done. And so essentially this has uh, uh, two different uh, approaches that allows us to talk about why using it in this way is more beneficial than smoking the cigarette. Is that one, we're still going to be stimulating the receptor. So we're going to be avoiding all these withdrawal symptoms that come from the loss of stimulation because the receptor still being stimulated the same way. So what this does is it allows someone to quit cigarettes, to not have to use a cigarette in order to stimulate the receptor. So they're not getting all those harmful carcinogens, they're not, inhaling all those nasty things into their body, but they're still stimulating the nicotinic receptor. So that's why it's beneficial. We're still stimulating it, but we don't have to use a cigarette or chewing tobacco or something nasty in order to get that same stimulation. Now, in that same way, we could use something like a nicotine gum or the transdermal patch to get the same effect, right? We can agonize the nicotinic receptor and we'd still get the same avoidance of those withdrawal symptoms. And either one of those is more beneficial than smoking the cigarette. So whether you go through a transdermal patch or use nicotine gum or you use Chantix, you're still going to be stimulating the receptor without having to inhale the carcinogenic cigarette. Now, what's important to know about varenicline is that, or let me mention this too before, is that we would be using these drugs, varenicline or the transdermal patch or the nicotine gum, to help someone come off of using cigarettes to prevent the addiction from continuing. And so what we would do is that over time we would reduce the amount of nicotine or the Chantix that the patient receives, and that would slowly avoid the withdrawal, so that way the person doesn't have that anxiety or the irritability. But they're uh, and they're still not resorting to using a cigarette. One important thing to know about Chantix, and you probably heard this before, is that it causes really, really weird dreams. And so when you advise your patients, this is definitely something you're going to want to mention to them. And it can be a reason for why people stop, is that they have really, really vivid dreaming when they're on varenicline. And so that's going to be our first two drugs that kind of cover what the kind of general nicotinic receptor agonism. And what we're going to do next is we're going to jump onto purely the muscle side of the nicotinic receptors, and we're going to look at some pretty interesting uh, applications of using drugs that antagonize or agonize the muscular nicotinic receptor. Now, as a reminder, I put this in just to give you a diagram of what happens at the neuromuscular junction. The nerve impulse comes down, reaches the nerve terminus, that uh, opens these voltage gated calcium channels, which allows calcium to flow inside the cell, which allows the vesicle to move towards the membrane, fuse to the cell membrane, and release the acetylcholine. The acetylcholine will move across the synapse, where it will bind to the nicotinic receptor, which will cause the influx of sodium, which depolarizes inside the cell, which causes calcium influx into the sarcoplasmic reticulum, and then which eventually leads to uh, the nerve impulse being transmitted into a muscular movement, a contraction. And then, of course, we have acetylcholinesterase, which terminates this nerve stimulus by breaking down acetylcholine into its parts. And so we have a collection of drugs, which you'll notice all end in very similar endings, curonium or curium. And these are the nicotinic receptor antagonists, or what they're known as more as the non-depolarizing neuromuscular blockers. And so if we look at this word, neuromuscular blocker, so what that's saying is that we're preventing the nervous system from activating the muscular system, the musculature. And we're going to be doing that by preventing the depolarization of the muscle cell. So what we're going to be doing is we're going to be preventing the sodium. We're going to be preventing the acetylcholine from binding to the nicotinic receptor, which prevents this influx of sodium. And so we're not going to be able to transmit this nerve impulse to culminate in a muscle contraction. And so what this is going to result in is that we prevent muscle movement. And so we uh, we essentially, in pretty much one go, prevent the patient from being able to move. Now, this isn't useful in any setting except during a hospital setting where we're trying to intubate the patient or the patient is going into surgery. And so, why we would do this is during intubation, which they're sticking the breathing tube through the throat, we want to relax the muscles in the throat so that way we can widen them. We can prevent the constriction so that way there's a wider opening to be able to put the breathing tube down someone's throat. Likewise, we would administer this before surgery so that way the muscles aren't constricting and resisting the surgeon trying to cut through the muscle layers as they're performing, whatever issue they're going on. So if you're, cutting through the stomach and you need to uh, cut through that muscle that's covering, maybe the intestines or the stomach, or whatever you're trying to go for, as you're cutting through the muscles in the abdomen, by administering one of these non-depolarizing neuromuscular blockers, you're going to relax the muscle, and it's going to be able to be easier to cut. Now, one of the big things to bear in mind is that this can lead to apnea, or the paralysis of the diaphragm muscle. So if we don't if we're worried about the patient not being able to breathe, this can be a really big issue with uh, with these drugs. Is that someone is unable to continue uh, because we paralyze, or unable to breathe, and potentially continue the surgery because we have paralyzed the diaphragm. Now, this list of drugs here, they don't always act the same. They work slightly differently. All right. And that pancuronium is a slow onset, slow duration kind of drug. And when we think about that, that's not incredibly useful to have a slow onset. Because if we're trying to intubate someone, it's probably in an emergency setting that we want to put the tube down their throat and support their breathing. And if we're administer someone pancuronium, then we're going to be waiting for their uh, their throat to slowly stop contracting, so it dilates enough for us to be able to go through the breathing tube, to be able to go through their trachea. And so we would rather use something like pipocuronium, curium, one of those, which has a quicker onset. And that quicker onset is going to allow for us to rapidly relax the muscles, so that way we can intubate. The other effect of using a quicker onset drug is that it's not going to scare the patient, because it's going to happen so quickly, and we're going to get that right down their throat. We're going to have this happen in a way where they're not slowly feeling like they are losing control. So in two ways, it allows quick intubation, and it allows us not to scare the patient. Now, likewise, by using a slow duration, that's beneficial because it means that we're going to be having the drug act for a longer amount of time. So we don't have to keep dosing the patient when they have the tube down their throat. Because what's going to happen is they're going to cough, and they're going to panic and try to dislodge the tube when it's doing the breathing for them. So that relaxation of the muscle is going to allow the patient to feel more secure with the breathing tube. The other fact that we have to talk about is with the role of releasing histamine. And some of these drugs have different effects on the mast cells and the basophils found in the blood vessels. And so when you release histamine, that's going to dilate the blood vessels. And what that's going to do is it's going to lower someone's blood pressure. So if you have someone who's, in shock because they're losing blood loss, you wouldn't necessarily want to use a drug that has a higher chance of releasing histamine, because that's going to lower their blood pressure significantly, and it might put the patient in danger. So pancuronium has a lower chance of releasing histamine, which means it has a lower chance of lowering the patient's blood pressure. Whereas pipocuronium has a higher chance of releasing histamine. And so this is one of those things where, depending on your patient, you're going to have to choose, if you look at the full list of these drugs, which one you'd rather use in in the emergency setting that you're in, depending on what the patient is doing. Now, this is all well and good, but if we want to revive the patient, if we want to um, uh, reverse the effect of the blocker, then what we're going to do is we're going to use an acetylcholinesterase inhibitor. And so, in normal function, as we can see, the nerve impulse comes down, the acetylcholine is the vesicle fuses to the membrane, releases the acetylcholine, which would cause the nicotinic receptors to be stimulated, which would cause them to open, which allows sodium to flow inside the sarcolemma, which would cause a depolarization of the muscle and a contraction. When we administer a non-depolarizing muscle blocker or muscle relaxant, that's going to block this nicotinic receptor, and so we're going to have no contraction. And all of our acetylcholine is going to go right through the cholinesterase and be broken down. However, when we use an acetylcholinesterase inhibitor, which is what this is in pink, we're going to be increasing this concentration of acetylcholine, which is going to compete with the neuromuscular blocker. And slowly over time, what's going to happen is that if we continue the blockade of the acetylcholinesterase, slowly the muscle relaxer, the muscle blocker, will diffuse away and be taken to the liver to be eliminated from the body. But we can keep the acetylcholine high and compete, which will allow for those muscle contractions to come back. And this can be a pretty quick process. It can, probably within half an hour or maybe a little bit longer. And so administering a acetylcholinesterase inhibitor like physostigmine, uh, neostigmine. Let's see if we can go back to those drugs real quick. The pyridostigmine, all these drugs here allows for us to revive the patient and reverse the effects of the non-depolarizing neuromuscular blockers. Now, there is another drug that goes by Sugamedics, and this is a kind of a funky looking drug because what it is it looks like a pore. It looks like a donut, a ring. And what it does is that it binds rocuronium or vecuronium specifically. It's an antidote for these drugs where the Sugamedics will scoop up these two drugs and will bind to them, which prevents them from blocking the nicotinic receptor. And so if you had administered the rocuronium or the vecuronium to a patient, you could give them Sugamedics as an antidote to their paralysis. And then eventually, this complex is favorable to form and then it will be eliminated from the body. So, two different ways of reversing the paralysis due to these non depolarizing muscle blockers. One through using acetylcholinesterase inhibitors, and the other one is through using Sugamedics. Now, another important way of creating paralysis in a patient is using succinylcholine. And succinylcholine is described as a depolarizing neuromuscular blocker. And if you look at these two structures between succinylcholine on the bottom and acetylcholine on the top, you'd notice that they're very similar in structure. They both have this ester moiety, which is connected to this quaternary positive ammonium. And because of the similarity between these, it allows for the succinylcholine to have affinity for the nicotinic receptor, but it's only selective for the muscular nicotinic receptor. Likewise, because it's physically different than acetylcholine, it's more resistant to the action of acetylcholinesterase. So that means it's going to have a longer duration of action than the acetylcholine. Now, what happens here is that the succinylcholine binds to the nicotinic receptor. I can actually go back to this picture. And actually, let me go to here. Let me make sure this is still recording. Perfect. What happens is that we have our nerve. Here is our sarcolemma, our muscle. And on it, we have our nicotinic receptors. Whoops. I'm on the wrong layer. Here is our nerve. Here's our sarcolemma. And here's our nicotinic receptors. So what happens is that when we administer the succinylcholine, it comes into the synapse and binds to the nicotinic receptor. Now, don't forget that acetylcholine, when it's released from the nerve, from the vesicle, it's also doing the same thing, right? Succinylcholine and acetylcholine have the same function. They're both going to stimulate the nicotinic receptor. The difference is that acetylcholinesterase will break down acetylcholine and it will terminate the response. But because succinylcholine resists this acetylcholinesterase, it has a prolonged stimulation of the muscle. And so what happens is that we have a constant depolarization of the muscle. And it's not able to repolarize. So if you constantly depolarize the muscle, that means you're going to cause the initial muscle contraction. But because we're not allowing to repolarize, the muscle is never going to relax. And since we are never going to allow the muscle to relax, that causes paralysis. So compared to the non-depolarizing blockers, neuromuscular blockers, they relax the muscle, versus succinylcholine causes hypercontraction of the muscle because it doesn't allow for the depolarization of the motor end plate. We're constantly stimulating it. We're not going to let the stimulation stop. So that way we're constantly contracting. You never relax. So you are now paralyzed. What's going to happen is that when you administer the succinylcholine, within a few seconds, you're going to be causing rapid muscle movement as all of the muscles in that person's body are going to start to contract. And then after those rapid muscle movements, initially, all of the muscles are going to become depolarized and the muscle contraction is going to stop. What's important to know here is that succinylcholine has a short acting uh, duration of action that's pretty short. It's longer than acetylcholine, but it's shorter than some of our other drugs going on. But there's a fact that about 1 in 2,000 people have a deficiency in that acetylcholinesterase, that pharmacogenetics. And so what that means is that over time, even though the succinylcholine is resistant, it's not completely resistant, it's just more resistant. So that acetylcholinesterase is still going to break it down, but if you have a deficiency, then you're going to have an even longer duration of action and even a longer paralysis. So repeat that what it is. Succinylcholine is broken down by acetylcholinesterase. However, it's more resistant. So it means it has a longer duration of action than acetylcholine. However, 1 in 2,000 patients has a deficiency in acetylcholinesterase. So that's going to increase the uh, the stimulation in the nicotinic receptor, preventing the repolarization of the motor end plate. That's going to increase the duration of action, which is going to cause a longer paralysis. There's an important thing to know about succinylcholine is that it can cause uh, a a um, it can cause a adverse effect called malignant hyperthermia. And so the way that the body heats itself is through muscle contraction, is that releases a little bit of energy, which we can use as heat, and that heat over the course of the day keeps our body at a nice temperature. This is also why when you're cold, you shiver, because the more muscle contractions means you are raising your body's temperature, and you're going to be preventing a dip in your core body temperature. When you use succinylcholine, because you're going to be rapidly causing so many muscle contractions, you can actually raise the temperature of the patient to pretty dangerous temperatures, 106 Fahrenheit. And that could cause, multiple different problems. Uh, and what's important to know is that if this happens, uh, you have to cool down the patient to prevent uh, uh, the uh, the effects of the hyperthermia. And then I believe, cool. So that is all we have to talk about for the nicotinic receptors. Hopefully, going a little bit slower or just focusing on this one aspect was a little bit better. Give me some feedback of what's going on. Feel free to text me. What we're going to be talking about next is kind of a big topic where we're going to be talking about the beta adrenergic agonists and their antagonists, the alpha adrenergic. Uh, Pretty big topic, really, really in depth. Hopefully, we'll be able to go through it, maybe one, maybe two different um, sessions, but it should be good. I'm excited. Um, but we will save that for possibly Thursday, depending on what people want to do. Let me know. I'm always happy to do what it takes. All right. I will see you all later. Thank you for listening.